Assalamu alaikum. Welcome to California Care. Here's another tip today. A patient needed an RCT done on the lower first molar on the left side. I gave him inferior alveolar nerve block and his lip went numb and it was feeling thick to him, and that was fine. As a good measure, I also give always, when I'm working on the lower arch, I give mylohyoid block as well. For that, I go to the apical region into the lingual area, into the lingual vestibule of the tooth required, and I administer a bit of anesthetic, which might be just like quarter of a cc, quarter of a milliliter. So I also gave mylohyoid nerve block to him, and I started to proceed with the RCT procedure by gaining the access to the pulp chamber. Decay removal and the restoration removal was okay, but the moment I got to the pulp chamber, he jumped. He had a lot of pain. Now this tooth was totally numb. On the facial, he had no pain. The buccal nerve block was there as well. His lip was totally numb and he still had a lot of pain. So I went ahead and gave him gow gates. Right by the condyles, I gave him gow gates, and then he told me, yeah, the whole face is almost gone. And he was profoundly numb. I went into the pulp chamber, he had pain again. Mind you, it was a mechanical exposure from the last restoration that the patient had, and that's why we were in necessity of doing an RCT treatment at this time. I couldn't figure out why that would happen. I gave PDL injection with Ligmaject. That also did not work. Every time I would touch the pulp chamber, he would jump, literally a lot of pain, and everything else was numb. So I decided to give directly intrapulpal injection. And I took the needle and I went in, and he could not tolerate the pain. So what I did was, some thought came to me. I took the needle. This is a schematic of the needle with the inside lumen and the outside metal of the needle. This is enlarged, and that being the tip. I went ahead and cut it right there. Once I cut it, no longer it was a sharp edge right there, but it became a tube. Then I trimmed the sides of the metal by holding a burr to it going all around, and this tube of the needle became thin. So eventually it kind of looked something like this. This was the inside lumen of the needle, flush cut on the tip, and it was thin enough to get into the tiny hole that we had made, which was about less than quarter millimeter in a diameter with a tiny little burr. I went in and I injected the anesthetic, and he was all numb. He had 4 canals, both mesiofacial and mesiolingual. I was able to negotiate all the way to the tip and clean them and shape them. Distal facial was also accessible without any further pain, and I did it all the way to the tip and I cleaned it up. It was a distal lingual he had pain again. The chamber was open and I could see the canal itself. So I did the same thing. I took this tube, needle that is now turned into a tube, and I plugged it in to the canal, and I started injecting very slowly with the Ligmaject, and the tooth was numb. That final canal was numb as well, and I was able to go ahead and clean it all the way to the tip and shape. The only difference was that instead of using lidocaine intrapulpally, I use articaine. Articaine 4% is a very, very good local anesthetic that works. It has very good permeability into the soft tissue and into the bone, and sometime in wisdom teeth also I use it. The only caveat being that articaine cannot be used as an inferior alveolar nerve block, because there's a certain chance of paresthesia recorded on history of people who have had articaine in inferior alveolar nerve block. Other places you can use it freely, and intrapulpal you can also use it. So I thought that might be helpful for you to be able to convert a regular needle into an injection tube that you can utilize to give an injection directly into the pulp chamber. I hope that helps. Take care from California Care.